Thanks, everyone. I'm Eziafa Oduah. I'm one of the medical thoracic oncologists at Duke Cancer Institute, and it's my pleasure to be here to talk about updates in lung cancer treatment. I do have to say that lung cancer is one of those fields where things are really turning around, and there is no way that can cover all the updates. But what I wanted to highlight today were what I consider practice changing, recent advances that we've had in the past year that I think should really be standard of care today. And so just as an introduction, and these are my disclosures, I want to talk about a little bit of introduction, a bit of a background in lung cancer, part of what Dr. Oliver was talking about. And then I distributed in terms of small cell lung cancer and non-small cell lung cancer, and I'll have summaries in between so it's not too complicated at the end. And so, as you all know, lung cancer remains the leading cause of cancer mortality in the United States and worldwide. She pointed to this earlier. It is the second cancer in male and females, but the degree of death and mortality is really high, and it has remained the same over the past several years and really hasn't changed much. This is despite, all the advances we've had in treatment landscape, where initially we just had chemotherapies, then we had immunotherapies and targeted therapies in non-small cell lung cancer. Despite these changes and everything we're learning in a very rapid pace, I think that the decrease in mortality might be seen later on as the data rolls out in the future. So I wanted to start off by, kind of talking about what do I think about as a medical oncologist when I see a patient with lung cancer. What are the, usually I tell my patients there are 4 things I want to know. I want to know the histological subtype of the lung cancer, whether it's small cell or non-small cell. I want to know the stage of the lung cancer and the molecular alterations, which she alluded to earlier, meaning the changes in the DNA of the cancer cell, not the changes in the person's DNA. And then also, most importantly, I want to know you, the patient, who you are, what your activity level is, and to help me understand what kind of treatments will best be suited to you. And this is because the therapeutic landscape for lung cancer is really different if you're talking about small cell versus non-small cells. Small cell is more aggressive but less common, about 15% of all lung cancers. Non-small cell is a more common one, about 85% of all lung cancers. Less aggressive, but really also high mortality rates. And so as you look in this, the treatment can go from surgery to surgery plus systemic therapy, radiation therapy. And then as you get more advanced in extensive stage, you're really limited to only systemic therapy. And in those cases, we may be able to use radiation therapy more as palliative, meaning that maybe as symptom control, but not as a means of curing the cancer. We would like to cure all lung cancers, but really today, we consider early stage lung cancer as potentially curable, but stage 4, late stage, we consider it as yet incurable, but we know that many patients are living longer with their lung cancers. And so I wanted to start off with some updates in small cell lung cancer. For many years, we're only hearing about non-small cell lung cancer updates, so we're really excited this last year with 2 major updates, and this was presented at ASCO this year in 2024. This drug tarlatamab, it was investigated in a phase 2 trial where they analyzed the efficacy and safety of the drug. Now, tarlatamab is one of the newer treatment paradigms that we are developing in lung cancer, which means we call it a BiTE, which means a bispecific T-cell engager. T-cell is your immune cell. The small cell lung cancer cell is there. So what the tarlatamab does is bring closer your T-cell, which is the immune cell that kills the cancer cells, to the cancer cell, such that the T-cell then leads to T-cell expansion. You have more of those killer T-cells that then release the enzyme with that kill the cancer cells by apoptosis. So that's kind of like, I'm not going to go into a lot of details about that, but I just wanted to share what this drug tarlatamab actually does. And so this study investigated this drug in patients who had been previously treated for small cell lung cancer. They initially investigated 2 different doses, 10 milligrams and 100 milligrams. What they found was that there was no significant difference in survival between the 2 doses. Actually, the 10 milligram tended was probably better than the 100 milligrams, and so they went forward with the 10 milligram dose. And this is a summary of the efficacy. So in patients with small cell lung cancer who have extensive stage disease, regardless of the presence of brain metastasis, which is one thing that we actually do worry about quite often in lung cancer, the responses were pretty impressive in both the objective response rate, meaning all patients in whom the drug either shrunk the cancer or kept it under control. And as you can see here, in the overall survival, meaning median overall survival, the average of how long they lived, you're seeing 14.3, and these results are really quite impressive because previously for extensive stage small cell lung cancer, we're talking about 6 months. And so we're seeing patients living more than double of what we see with standard of care. And so due to these results, the FDA approved this drug in small cell lung cancer, and it's actually now in the NCCN guidelines as standard of care treatment for patients with small cell lung cancer after they've progressed on the initial treatments. And then the next study I wanted to bring up was this Adriatic study in small cell as well. Now this is for limited stage, early stage small cell lung cancer, where if you had anybody who had small cell lung cancer in early stage, usually treated with chemotherapy plus radiation therapy. And usually up until this study came out, after that treatment we stop and we just follow the scans to see when it comes back, if it does come back. And so in this study, they actually investigated the addition of this drug durvalumab after the chemotherapy and radiation, and they gave the patients a drug for several going on. Either they randomized patients to get durvalumab, which is an immunotherapy drug, or placebo, and they followed the patients. And so here is the overall survival curve here. I'm just going to summarize that the hazard ratio, meaning that the addition of durvalumab decreased the chance of the cancer coming back, and also increased in this study more of overall survival by 27%, based on the hazard ratio favoring the addition of durvalumab. Now this also became a really interesting finding for us in lung cancer, in small cell lung cancer specifically, after several decades of not having any advances in this field. And also, as you can see in this subgroup analysis, it benefited almost every category of patients. And so the summary of this is that tarlatamab is FDA approved and is in the NCCN guidelines for extensive stage small cell lung cancer in the second line. And so everybody should be able to get it. Consolidation durvalumab should now be the new standard of care for limited stage small cell lung cancer after concurrent chemoradiation, because we do see overall survival benefits with the addition of durvalumab. I haven't included this here for the interest of time, but we are now also seeing that there are studies looking at molecular profiling in small cell lung cancer. The molecular changes that I talk about, that we talk about usually now, are mostly limited to non-small cell lung cancer, but there are studies indicating that maybe there might be some molecular profiling that we can use in some patients with small cell lung cancer that could also help us better define and define the treatment strategies that we use for them. And so I will move now to non-small cell lung cancer in early stage, for patients who have ALK positive. And so this study was published in April of this year in the New England Journal of Medicine. And this was the addition of alectinib, which is an ALK inhibitor, to patients after surgery. And so the study design really was patients who had stage 1B, and that meant that the tumor size was 4 centimeter or greater, to 3A non-small cell lung cancer, and they had this ALK mutation in the DNA of the cancer cell. And so they randomized patients 1-to-1 after surgery to either get the standard of care, which is chemotherapy, or alectinib for 2 years. And so they followed them along to see when will the cancer come back. And again, in this result, you can see here, alectinib outperformed the chemotherapy with a hazard ratio of 0.27. So it decreased the chances of 0.24. It decreased the chances of this cancer coming back by 76%. That is huge compared to chemotherapy. And so I don't, and if you look at patients who had also CNS disease, the occurrence of CNS disease, alectinib also outperformed chemotherapy. And so previously, whereby we were using just alectinib or ALK inhibitors in more metastatic stages, now we can use these drugs in earlier stages to decrease the chances of the cancer coming back. That is what we want to do. And so now, alectinib was the only ALK inhibitor that has been studied in this space. There are other ALK inhibitors, but they just haven't been studied in this space yet. So for now, we have alectinib as the only drug that is FDA approved and also in the NCCN guidelines for patients who have ALK positive mutations in the cancer cell after surgery. And so what about EGFR mutation? We have an update there as well. And so, as I explained, for patients who have more advanced disease, for whom surgery alone is not an option, who would get chemotherapy and radiation therapy, previously the only FDA-approved regimen was really to put them on immunotherapy consolidation. But we know that patients who have ALK alterations, EGFR alterations, those patients usually do not respond to immunotherapy because their cancers aren't driven immunologically. Their cancers are driven from these mutations that cause the cancer to progress. And so this study investigated the addition of osimertinib, again, which is an EGFR-targeted therapy that we use in stage 4 disease classically. And so they looked at patients who have stage 3 disease after chemoradiation and gave them osimertinib versus placebo, and here is the study design. And so what they found, again, the progression-free survival, you can see this comes very separate, whereby osimertinib clearly outperforms the placebo group by a hazard ratio of 16, which means that the addition of osimertinib decreased the chances of the cancer coming back by 84%. Those are impressive numbers. And so, again, regardless of who looked at it, whether it was the investigator or the blinded review committee, we saw similar results. Benefit was also across all groups for the most part. And for now, we don't have a survival benefit in this, and why is that? Because first of all, they're saying the data isn't mature, but I really don't think we're going to see the data mature to give us an OS benefit because they allowed patients, which was the right thing to do, who were on placebo to get on osimertinib, their cancer came back. And so, because there was no other way to do this trial in an ethical manner. And so that's why we're not really seeing an overall survival benefit, in my opinion, from here. We'll see many, in a couple of years when that data matures, if we see any, but I won't be surprised if we don't see that just because of the study design. And this is just a description of how they allow patients to cross over. 81% of patients were actually able to cross over to osimertinib by the completion of the study. And so osimertinib became FDA approved and is now included in the NCCN guidelines as standard of care for patients with stage 3 disease after definitive concurrent chemoradiation therapy. And so the reason why all this is important is historically, I know you probably had a talk about getting DNA testing for the cancer cell already. Usually we were more saying that was more important for stage 4 disease, but that is not the case now. For early stage disease, for all patients, we should be getting molecular testing because in early stage, we can use these drugs over what previously used to be standard of care. And so whatever the stage of the cancer is, I think I and most people in lung cancer would advocate to get molecular testing done for this patient because it can really change the treatment that they get and improve their outcomes. And so in summary, adjuvant alectinib after surgery is a standard of care for stage 2 to 3B non-small cell lung cancer after surgical resection. Consolidation osimertinib is now also a new standard of care for EGFR exon 19 L858R after chemoradiation therapy as well. I didn't include immunotherapy in this. The neoadjuvant perioperative immunotherapy data came out over a year ago. There's still stuff going on there, but in my opinion, and if you have any questions about that, we can talk about it. I believe that what we should be doing now is really looking to improve the rates of pathological complete responses after neoadjuvant therapy. And so we do have clinical trials at Duke that are trying to look at mechanisms to improve the rate of PAT-CR in patients who got neoadjuvant therapy followed by surgery. And so moving on to late-stage non-small cell lung cancer, again, ALK-positive patients. This is in stage 4 disease now. Lorlatinib is a drug that is already approved in this stage, but at ASCO this year, they presented the results of the CROWN study, in which patients with stage 4 disease or unresectable stage 3 disease were also randomized to lorlatinib or the older generation ALK inhibitor crizotinib and followed. The interesting thing about this, and I'm going to go through the slides, is also here you're seeing a hazard ratio of 0.19, which is equivalent to 81% improvement with the addition of lorlatinib compared to crizotinib in patients with ALK positive. Now, these results were not very surprising to us, but it was really good. And also, the median PFS was not reached, meaning that a lot of patients were still on this drug and did not have a recurrence of their cancer while they were on this drug for a really long time. There are other drugs that target ALK inhibitors, like alectinib in early stage is also used in late stage. There are there are nuances between the use of alectinib versus lorlatinib, but I wanted to point this out because these results are impressive. We do not have the overall survival data to see if it compares more favorably to other ALK inhibitors that are out there. But I think that is something to talk about when if you know someone who has an ALK positive late stage non-small cell lung cancer and they're considering what treatment option to use. And so if you look at the NCCN guidelines, alectinib, brigatinib, and lorlatinib are all considered category 1 evidence for patients with ALK rearrangements in their cancers, and any of them really can be used. The question is lorlatinib really superior? And the answer is, for now, maybe, but we don't know. And so when it comes to KRAS G12C mutant, another data that came out recently was the Crystals 12 study looking at the addition of adagrasib, which is a KRAS inhibitor, compared to standard of care. Now, again, adagrasib is a drug that is already being used, but they gave us an updated result of the trial, which is not practice changing because we're already using it, so we know, but it does show that the hazard ratio for PFS, if you're using adagrasib, the targeted therapy compared to chemotherapy in this stage was 0.58, as you can see over there. So really showing that the use of adagrasib, if you have a KRAS G12C mutation, adagrasib is one drug, sotorasib is the other drug that is FDA approved, but this was the data that was updated this year at ASCO. And so what was interesting about the use of adagrasib is that adagrasib is one of the drugs, the KRAS G12C, that we actually have prospective data showing that it has good responses in patients with brain metastases. And so there are other KRAS G12C targeted therapies coming out. One of them was presented at ASCO this year. Olomorasib is another drug. And the interesting thing that they're doing now with KRAS G12C is trying to use them in combination with immunotherapy in the front line. Right now, KRAS G12C, if you have a KRAS mutation in the lung cancer, we're using them in the second line. We're using standard of care chemotherapy, immunotherapy first, and then when you progress, we put you on these targeted therapies. We're really trying to push the needle forward and move these drugs up. trying to do combinations with chemotherapy in the front line or with immunotherapy in the front line. We have, several clinical trials going on, even here at Duke as well, but none of them are standard of care right now. But I just wanted to highlight that there are several other, like numerous KRAS targeted therapies coming out in the market now. And I wanted to share this HER2 because there are several targets, but again, wanted to share what I felt were the most potentially practice changing going forward updates. Zongertinib is a new drug that targets HER2 mutation and is being investigated in this in this trial called the Beanium Long 1 trial, based on studies that showed in the phase 1 trials showing an overall response rate of about 35% to 44%, depending on the category that was looked at. In lung cancer, it was actually 44%. In other cancers, overall, it was about 35%. Impressive numbers. Now it's going on into a phase 2 trial now, trying to see if we can move it on into part of the standard to make sure that it's actually efficacious as well. And so in summary, for late-stage non-small cell lung cancer, lorlatinib remains one standard of care option for patients with stage 4 ALK-positive non-small cell lung cancer. Adagrasib remains one standard of care for stage 4 cancers, again with KRAS G12C. New KRAS targeted therapies are in clinical development, being tested alone and in combination with immunotherapy and chemotherapy. And zongertinib is a promising HER2 targeted therapy. All in all, I think there are many, things coming up in clinical trials with different mutations, and we're seeing a lot of advances. A lot of them are not prime time yet, but there's promise that we're going to keep moving the needle forward. And so with that, I want to thank everyone. I want to thank you all for your attention, and I think I have time for questions.
My name is Emily. I'm a physical therapist at WakeMed. I work in the pulmonary rehab clinic. We are located at the WakeMed main hospital, and then there's also a Cary office as well, pulmonary rehab clinic. So I'm going to be talking with you today about pulmonary rehab and how it can improve your quality of life, or a patient's quality of life who is suffering from any sort of pulmonary or respiratory condition. Okay. But first, we are going to breathe. So instead of but first coffee, which is the phrase that I like to say in the morning, this is but first breathe. So this might be a little tough because some people are eating lunch still. So don't aspirate your food while you're trying to do this. But what I would like for you to do is get into a position in your chair where you're a little bit reclined, and we're going to do a breathing technique to start off. So you're going to recline back a little bit, scoot your hips forward a little bit, and we're going to start with just diaphragmatic breathing. So a lot of people call it belly breathing. I'm going to talk about the benefits of this later on, but right now we're just going to try it. So first, put one of your hands on your chest and then the other hand right below your rib cage. And what you're going to do is you're going to try to breathe in through your nose, but as you do that, you want your belly to expand, and then you're going to breathe out through your mouth, and your belly should sink in. Okay, so for some people, they think of it as the opposite. So sometimes it really takes a lot of practice, and this is something that we practice with our patients, sometimes extensively, for them to get the right technique or the correct technique. But let's just try it. So I want you to breathe in through your nose. Your belly's going to rise. And then you're going to exhale out through your mouth, belly is going to fall. And then do it again. Inhale through your nose, belly rises. Exhale through your mouth, belly falls. Okay, so Diaphragmatic breathing, as I said, can have many benefits that we'll go through in a little bit. So hopefully you feel nice and relaxed and ready for the rest of the presentation. So pulmonary rehab, according to the American Thoracic Society, is a comprehensive intervention that's based on a thorough patient assessment, followed by patient-tailored therapies that include, but are not limited to, exercise training, education, behavior change, that are all designed to improve the physical and psychological condition of people with chronic respiratory disease. And the most difficult part, to promote the long-term adherence to health-enhancing behaviors. So first, I would just like to describe kind of who should participate in pulmonary rehab. So basically, anyone who has shortness of breath at rest or with exertion, a diagnosis of a chronic respiratory condition, anyone who's been hospitalized for a respiratory condition, anyone who has decreased exercise or functional capacity. So I'm going to try not to get into the weeds with this, but not all patients will qualify for pulmonary rehab. But the referral, if a person would benefit from pulmonary rehab, they should still be referred. Of course, as we were talking about drug therapies and insurance coverage and screening and insurance coverage, it's the same thing with pulmonary rehab. So the formal pulmonary rehab group program, there's very specific criteria for that, for it to be covered by Medicare or other insurance companies. But even if there is not a qualifying diagnosis, which lung cancer by itself is not a qualifying diagnosis, don't know why, usually we can still provide the service, but it may be under a different billing code. So really it's just more behind the scenes trying to figure out how to help the patient get the services that they need, but still covered by their insurance. Okay, so the components of pulmonary rehab are a couple things. So first, I mentioned that they're specific in terms of insurance coverage. So I'll go through these and kind of apply it to how it's actually done in the clinic. So patient assessment is the first one. So we, anytime a person gets a referral for pulmonary rehab, in our clinic we do a physical therapy evaluation for that patient, but we do provide a cardiopulmonary assessment. We review their medical history. We do lots of questionnaires and things to get a sense of where they are. And then there's the part about the exercise training, which is what most people think about when they think about pulmonary rehab, which I'm going to talk about a lot more here in a second. Then there's psychosocial assessment and support. In our clinic, we do have a stress management counselor that patients can schedule times to talk with, and that's just included within the program. It's not a separate referral or separate billing or anything like that. Also outcomes measurements. So we do outcomes, physical outcome measures such as the 6-minute walk test. Some of you may have heard of that, as well as the SPPB, which is a short physical performance battery, and that looks at balance and functional strength. And we do that at the beginning, also kind of towards the middle of the program, and then at the end to see are we making an impact on these measures for the patients that we're working with. And then also an individualized treatment plan is provided once we have done all of these assessments to determine what in particular this patient may benefit from. Many of the patients that we receive referrals for have a lot of other medical history besides their pulmonary condition. So we have to consider those things and try to make an appropriate exercise program for them. The other thing is that many of the patients that we receive referrals for are scared or have difficulty exercising because of their shortness of breath, and we're able to help them find something that they can do that they feel comfortable doing, that hopefully they can continue as well. Okay, so as I've already mentioned, exercise is a major part of pulmonary rehab. There is extensive evidence for the benefits of pulmonary rehab for those specifically with moderate or worse COPD. That's where most of the research has been done with pulmonary rehab. But I'm going to review today the evidence on the benefits of exercise with patients with cancer, and then also specifically lung cancer. So it could be other types of cancer with this first study that I'm mentioning. So there was a systematic review done of 42 studies on exercise with patients with cancer during active treatment. And exercise led to improvements in cardiorespiratory fitness, strength, fatigue level, quality of life, as well as a decrease in depression and anxiety. And then the other really great part is that it was found to have a low risk for adverse events. So they were able to participate in this exercise, get the benefits out of the exercise, and there was very low risk for something happening medically with them. I think that's a lot of times the fear that patients have, is that they just really won't be able to tolerate exercise. So in the same review, there were some studies that indicated that preoperative exercise in patients specifically with lung cancer led to a reduction in postoperative length of hospital stay, as well as postoperative complications. And then according to meta-analyses performed by the Cochrane Review in 2019, in people following lung resection for non-small cell lung cancer, aerobic and resistance exercises led to, as you can see, improved exercise capacity, improved quadricep muscle force, improved the physical component of their health-related quality of life, as well as a decrease in the participant's shortness of breath. Okay, we're going to breathe again. So the next breathing technique is generally an easier breathing technique to utilize for people to just kind of pick up and start to use. And it's also a breathing technique that can be used for people who are short of breath while they're exerting themselves or while they're short of breath. So this is pursed lip breathing, which I'm sure many of you have heard of. But you basically what you do is you breathe in through your nose, and then you breathe out through pursed lips. You don't pay attention really to what your belly is doing. And pursed lips is, I'm sure you've heard the phrase like, smell the roses and blow out the candles. So the idea is that you breathe in through your nose and then blow out through your mouth through pursed lips. Like that. So everybody try that. And it's best when you do pursed lip breathing to breathe in for half as long as you breathe out. Okay, so we're going to breathe in 2 seconds and then out 4 seconds. So breathe in through your nose, 1, 2, and then out through your mouth, 1, 2, 3, 4. And then in through your nose, 1, 2, and then out through your mouth. 1, 2, 3, 4. Okay, so this can be used in a variety of ways to help people who have shortness of breath. Okay, so this is more of just kind of a general information about what the National Comprehensive Cancer Network recommends for exercise for patients with cancer. And the recommendation is 150 minutes of moderate intensity aerobic exercise 3 to 5 sessions per week. So that's pretty similar to just your standard recommendation for any adult, as well as resistance training at least 2 days per week as part of a program lasting 6 to 12 weeks. It's also recommended that exercise interventions should at least initially be supervised by a PT or some type of exercise specialist to help the person get on the right track with appropriate exercise to make sure that it's safe and appropriate for them. Okay, so more about breathing, because breathing retraining is definitely a part of our pulmonary rehab program. So with diaphragmatic breathing, the one that we did first, the diaphragm is the most efficient muscle for breathing. So the idea of practicing diaphragmatic breathing, it can be utilized in the moment for a patient who is short of breath, but not as often. It's more so that they practice diaphragmatic breathing to help the diaphragm function more effectively or more appropriately. So the diaphragm also, when you activate the diaphragm, it allows you to use more of your lung capacity than when you're just utilizing muscles like in your neck or your shoulders. People who have chronic respiratory illness and who have had shortness of breath for many years, they tend to really overuse all of these muscles, and those muscles are not as effective for breathing. So if we can teach the person diaphragmatic breathing, then they can breathe more effectively even when they're not necessarily practicing it. So on the next slide, this was a video, but I can't connect to it from here. But it just shows, I wish I could see it from the different angle, but it just shows that the diaphragm is a very large muscle that sits like at the bottom of your rib cage. And as you inhale, the diaphragm comes down, and it allows for air to come into your lungs. And then as you exhale, the diaphragm comes up and it pushes the air out of your lungs. So like I said, when it's functioning appropriately, it can really help a person's ventilation. Then going back to pursed lip breathing. So with pursed lip breathing, with the actual technique, it actually helps to keep the airways open or more open. So when you breathe out through the pursed lips, it keeps the airways open to allow for more air exchange. And then, as I mentioned, I do feel like it is the easiest breathing technique to incorporate quickly or to teach a patient quickly. I feel like it can even be taught just in the clinic or at a fair or anywhere that you are. That is a really effective breathing technique to utilize. And it's amazing when patients have been short of breath for years that it's a new technique for them many times when they come to our clinic. So recovery breathing, that is really just referring to as I mentioned, you can't really focus on diaphragmatic breathing well if you're already very short of breath. So there are certain recovery positions that people get into that we help people understand that they can utilize if they are short of breath. One of them you may have heard of is like a tripod position. So where you sit and you see people in the hospital, if they're very short of breath, they put their elbows on their legs near their knees. And what that does is it actually helps put the diaphragm in an appropriate location to work more effectively. And it also sets up the respiratory muscles to work more effectively as well. So some people teach this to themselves because it's a way of breathing when they feel short of breath. So some people just automatically learn it, and then other people are like, oh, I never knew that. Paired breathing is simply pairing breathing with a movement. So the idea is that we practice breathing, doing certain movements with patients so that then they can pair breathing while they're doing tasks that make them short of breath. So like while they're bending over or while they're lifting something or while they're unloading the dishwasher and doing the laundry. So an example of a paired breathing would be like, okay, so I want you to raise your arms up. As you raise your arms up, you're going to inhale. As you bring your arms down, you're going to exhale. And you make it so that the timing of raising the arms up and bringing the arms down is timed with your inhalation and your exhalation. Paced breathing, it can be useful when you're active. So it can be utilized with pursed lip breathing, but what you can do is you can pair your breathing with an activity like walking upstairs, for example. So you might breathe in as you walk up 2 steps and breathe out as you walk up the next 3. Or same thing when you're walking up an incline. You may take 2 steps as you breathe in, and as we talked about, it's good to exhale for longer than your inhale. So you may, as you take 2 steps, inhale. As you take 4 steps, exhale. So that's the paced breathing. Okay, so the other part of the education component for pulmonary rehab is energy conservation. So the idea is that we want to conserve energy to allow you to complete tasks that you want to complete during the day. So basically, it's the whole concept of working smarter, not harder. So for some patients, they tend to maybe cluster too many activities in the morning, and then they have literally no steam left to do the things that they need to do in the evening. So these techniques are really helpful for those people. So one is to prioritize. So the idea is that you decide what needs to be done today or at this moment, and kind of put off things that maybe could wait until later. Plan is that you would plan ahead to avoid extra trips. For example, when you're taking a shower, gather all the things that you need in one place so that you're not walking back and forth and back and forth. Or if you have a 2-story home, you kind of gather your things that you need, you go downstairs, and you stay there until you need to go back up. So those would be examples of planning. Pacing is, we have a lot of patients that it's kind of a running joke. Just people that are just used to just going fast and doing everything like really fast. And so a lot of what we teach them is that slow and steady wins the race, as hard as that may be for some people, that if they are, really pacing themselves, they can accomplish a lot more. They may not accomplish as much as they want to in the 5 minutes that they were hoping to get it all done, but they will accomplish a lot more. So we really focus on, not completing all tasks in a row, but spreading things out, and then also taking rest breaks. And then position is thinking about body position during tasks. So are there things that a person could do sitting down instead of standing up? I always say, is it really important for you to stand up for this task? And they're like, no. Okay, well, then sit down, and then you'll be able to do something that is really important for you later in the day. So the idea is that we have to spread out our energy over the course of the day and not use it all up on things that potentially aren't even very important to us, but we hadn't really thought about how much energy they take. Okay, so the other piece, as I mentioned, is stress management. So of course, we've talked a lot about breathing strategies, so I'm not going to go into that anymore. But meditation is something that we will introduce to patients. People who have shortness of breath, it's natural for them to feel anxious. If I couldn't breathe, I would be very anxious. So I always tell people that it's okay. Anybody who's short of breath would feel stressed or anxious. So meditation is something that we introduce. We might introduce them to a few minute meditation if they've never done it before. We might give them information on an app that they can utilize for meditation. But it is something that can be very helpful in recovery, but also just kind of getting through the day as well. Yoga or Tai Chi. A lot of yoga and Tai Chi are pairing breathing with movement, which is, what I've been talking about. So yoga and Tai Chi are great. And for some people, it may not be appropriate. For some people, it would. And so we try to help identify those people that maybe would benefit from yoga or Tai Chi in the community. Social engagement. I think somehow I missed one part of what I wanted to say at the beginning. I don't think I summarized for you at the very beginning. The pulmonary rehab group is an opportunity for patients to engage with others who have pulmonary conditions as well. So the idea of this pulmonary rehab program, with all of these wonderful things I just mentioned, the added bonus is that they get to socialize with other people who have pulmonary conditions as well while they're doing it, and that can be very, very beneficial for them. It can be quite fun for everybody, and people are like, oh my gosh, I'm not going to be able to do this group. I'm not like a social person. I'm not going to do this. And then I really think you're going to like this group. We could do it individually, but I think you're going to like the group. And then the majority of people do. So, and they really enjoy that engagement with others, because many people, especially during COVID, with a pulmonary condition, of course, have been more concerned about being out in the community. And so they have become very isolated. So for some people, this might be the first opportunity that they have to interact with other people. I mentioned counseling, the stress management counseling, and then also trying to figure out what people enjoy so that they will continue with these behaviors ongoing.
Thank you for that introduction. I am honored to be here today. Lung cancer is very near and dear to my heart. My father was diagnosed with lung cancer in 2001 and passed away in 2002. He was stage 4 when he was diagnosed, but at that time there were not a lot of treatment options that we have now. There was no biomarker testing being done, or at least not where he was. So I feel like I am in this role because I haven't sat in the chair that the patient has, but I have definitely sat right beside the patient in the caregiver role at home caring for him, even though I was already a nurse. It can be very difficult. So I understand where some of y'all are coming from, not only as the nurse navigator role, but from the family patient caregiver role as well. I was a nurse at the time my dad was diagnosed, and I knew after his cancer journey that I was going to be an oncology nurse, even though he only lived 5 months after diagnosis till he passed away. Just that 5 months, the interactions with the whole entire care team was wonderful. And I know that sounds bad. My dad passed away, but they made those 5 months that we had with Dad the best that it could be. They were wonderful. Can't say any better things than the care team. So I think that's one reason why I am where I am today, because of that experience. I've been a nurse for about 30 years. I'm telling you my age here. Age is just a number. I'm not worried about that. So the last 18 and so years have been in oncology, 10 years chemo infusion, and a little over 7 years as an oncology navigator at UNC. An oncology nurse navigator, I'm not sure if all of you are aware of that, but the Oncology Nursing Society defines it as a professional RN with oncology experience with specific knowledge who offers individualized assistance to patients, families, and caregivers to help them overcome healthcare system barriers. I know that's a lot of information. Let's see if I can do this carefully. So really, what is an oncology nurse navigator? Someone who helps you navigate through the oncology system from diagnosis to treatment to survivorship. We positively influence your cancer journey, your point of contact, and we connect your connection to the healthcare team. And I put this picture up there because sometimes that's what I feel like. The that I need a cape to be a superhero to help everybody and do everything that I do, but I wouldn't have it any other way. So an Oncology Nurse Navigator will be assigned to you either at diagnosis or during the lung cancer screening process. We want to make sure that you understand what type of cancer you have, because that really influences your treatment plan. We want to make sure that you understand what stage, and then we explain any other testing that may be needed. There's a whole lot of tests that involves in the initial workup, including a brain MRI, PET scan, and most importantly, biomarker testing. And we want to make sure that you understand all that. And unfortunately, it may be a delay in getting the biomarker test because they take at least 2 weeks to get back. And I know once you've had that diagnosis of cancer, you don't want to wait 2 more weeks to get a treatment plan. But that's very important that we wait. We are working with our thoracic oncologist at UNC and the interventional pulmonologist, so when they get the diagnosis, that they go ahead and do the biomarker testing on the tissue, so that by the time they get to see us, we either have them back or they're already in process, so it's not a delay. So the treatment. Treatment plans vary depending on your type and stage of surgery. These are several different types of treatment plans, and we've heard from the other doctors earlier today. Surgery, chemotherapy, immune therapy, targeted therapy, radiation, or combination. It depends if you have an early stage, 1 or 2, surgery may be your treatment, it may be your only treatment. You may have surgery and then you may have chemotherapy afterwards. It just depends on your process, and we may have a plan in place and you think, okay, I only have to have surgery. It's not in any of the lymph nodes, this and that and the other, it's just surgery. And then when they get to do surgery and the path comes back for some reason, you do have to have chemo or you do have to do radiation. So we have to explain the process and answer any questions because the treatment plan may change. So who is your care team? Oncology care has come a long ways, and we are disease specific, especially at UNC. So you'll have a primary oncologist. A lot of our, I'm sorry, I'm not really sure what's going on here. Here we go. So at UNC especially, and some of the other facilities too, you have a oncologist that only takes care of lung cancer patients or breast cancer. And some of our patients have more than one cancer, unfortunately. So they may have more than one oncologist. So it gets to be confusing because they have to call this doctor for the prostate cancer and then us for their lung cancer and then another doctor for, whatever it might be. So it gets to be confusing. And most care teams have an APP, an advanced practice provider, either an NP or a PA. We also have, very fortunate to have a pharmacist on our team, and all those APPs and CPPs are also disease specific, so you may have several of those involved in your care. If you've had surgeon, you'll have a surgeon on your care team, radiation oncologist, other people that we make referrals to, such as therapists, nutritionists, as well as a nurse navigator, and you may have more than one of those. I only deal with lung cancer patients. Some of the other navigators will take care of the prostate cancer, the breast cancer, whatever cancer you may have. So you may have lots of people on your care team that it can be confusing as who to call when. So the lung cancer screening program has a navigator. So if you are fortunate enough to be in part of that, where you are able to get a low dose CT, there is a navigator with that program, so you may actually be in contact with her in the beginning before you actually have the official diagnosis and referred to a medical oncologist. When you have surgery or interventional pulmonology is doing a biopsy, they also have a nurse navigator. And then the medical oncologist navigators, and then some clinical trials also have navigators. Usually, after you finish the screening program and you're done with surgery, they sort of step back and then the medical oncologist takes over. But we all work together to make sure that your needs get met. Sometimes because the patients are used to calling the surgical navigator, they'll get a call and then they'll forward it on to me. So we're not going to leave you out there floundering around because there's so many involved. We're going to make sure that your needs are taken care of. So roles and responsibilities of a navigator, educator. That's one of our biggest things. Educate, educate, educate. You've just been told that you have cancer, and now you come in and we give you all this information with lots of big words, some of them that you've never ever heard of before, and it can be overwhelming. It can be confusing. It's still confusing to me at times because there's so many changes that are happening, so I can understand where you're coming from. We make sure that you understand the disease process, like I talked about a minute ago, that you know your cancer type and your stage, and if there's any molecular mutations from the biomarkers. It's important for you to know, even if they aren't treatable right now, that doesn't mean 5 years from now there's not going to be a treatment. So it's important for you to know what type of cancer, what stage, and if you have any molecular mutations. We talk about the treatment options. And like I said a minute ago, they may change, and there's several different ones. And as you go on through your treatments, they may change again. Multiple additional testing. If you're having trouble, we may get a brain MRI that's not scheduled at the time because you're having some issues. We may get another CT scan ordered earlier. And I have to explain all that. Why? Just so that you'll know if there's any lifestyle changes that should be made. And we talk about other resources that are available to you. Support groups. We talk about LCI, make sure that you know that they are around and what they do, and any other resources that might be needed. So support. So everybody that has been diagnosed with cancer, it's life-changing, not only for the patient, but for the family and the caregivers. So we need to make sure that they have the support that they need, that they are coping with their diagnosis appropriately, and if not, make those referrals, whether they just need someone to talk to, or whether they need to see a psychiatrist, and maybe even need to be on medication. And like I said, these need to be coordinated with the family and caregivers as well, because they're going through it just like you are. They're not sitting in the treatment chair or taking the medication, but they are going through it. So we also coordinate care between your primary care doctor, your dentist. You're actively being treated and you want to go have your teeth cleaned. Your dentist is more than likely going to want a medical clearance from the oncologist. So we do that. Specialists, a lot of times you're seeing your oncologist this week, but you're seeing your primary care next week. And so we coordinate that we have labs drawn one time instead of having labs done at UNC this week and having to get stuff again next week. So we coordinate that. We help ensure that all treatments are covered by insurance, which is very difficult at times. We also can coordinate transportation services and any community resources that is out there for you. And we try to help you understand your insurance coverage. Insurance is tricky at times, but we will fight for you. We have people at UNC that their job is to appeal denials, and they are pretty good at it. So we make sure that you understand what's going on and let you know that we're going to work through it. And we usually end up working through it. Communication. Communication is very important. We may communicate with you by phone calls. It may be emails, and it might be MyChart messages. And some days it seems like it's all three. I may communicate with some patients, whichever is appropriate for the situation. If it's a quick question, I don't mind sending a MyChart message. But if I need to ask more questions, it's easier for me just to pick up the phone and call, "Hey, Mr. Smith, tell me more about this," instead of sending a MyChart message. "Can you describe your symptoms a little more?" And then him email MyChart message back, and then MyChart again. But that's, the patient's preference and the navigator's preference. But I'm a talker, if you can't tell. So when you are communicating with your navigator and your healthcare team, be honest. Make sure you tell them how you feel. I can't tell you how many times I'll go in and ask the patient, how are you? I'm fine. And you look over there and there's their wife, daughter, brother shaking their head, no. Or the next day they call back, he wasn't honest with you yesterday. He's really not doing good. Be honest with us. We want to help you, and we can't help you if we don't know exactly what's going on. So like I said, we may have to ask the family and caregivers as we get different answers. And then we have to re-educate as the treatments progress, make referrals as needed. Sometimes we actually even have to get additional appointments made if patient has been having some problems and haven't been eating well, and we'll get them come in and have labs done and maybe even some IV fluids. Sometimes those lab appointments and tests are done locally, so that's something we have to coordinate with a local hospital as well. And sometimes we just need to listen. Sometimes the patient just needs to be heard. You know, they want to vent, explain themselves, and we just need to sit down and listen to them, and the caregivers as well, because they're, like I said, right there beside you, and which I know you wouldn't want it any other way, but they are experiencing it as well. So just need to listen. So when should you make connections with your oncology nurse navigator? Anytime you're having uncontrolled side effects or adverse reactions, you know, if you have pain that's not controlled, if you have a rash, if you're not tolerating eating, you're having nausea, vomiting, diarrhea, any of those things, or if you have a question, if you're thinking, call. I'd rather you call me and ask the question, and I'll say, oh, that's normal, that's to be expected, but just contact us, let us know. And then, you know, you are your person. You know your body better than anybody. If something just doesn't feel right, you know, a lot of time the patient knows that things are going on in their body before we ever pick it up on a lab test or an x-ray. You know, I'm sure some of you that have been diagnosed with cancer, and some people haven't, but some people said, something just didn't feel right. I knew something was going on, you know, like you with the recurrent pneumonia, you know, that just isn't quite right. So when you feel that something's not right, let us know. So what can an oncology nurse navigator do for you? We can positively influence your cancer journey by making sure you understand what's going on and that you are involved in it. We can increase your knowledge, which makes a better adherence to the treatment plan, improve your quality of life, and become a support person, a listener, and a friend. I have gained so many friends over these years as an oncology nurse. When my kids were little and we would go out to the grocery store or somewhere, I would see a patient and I would just introduce them as my friend. This is one of Mommy's friends. And my youngest son said, gosh, Mommy, you sure have lots of friends. But you know, truly, I have made lots of friends from patients. So this is just some things that you need to know that can help you through the cancer journey. Avoid internet searches unless you know it's a reputable source. You know, a lot of times you go out there and you're reading somebody's personal blog and it's not evidence-based, it's not been tested, it's just their personal opinion on what either worked well or didn't work well for them. Advice from your friends, neighbors, and coworkers might not be relevant to your cancer journey. Cancer is so patient-specific nowadays that just because your neighbor 3 houses down has lung cancer, that doesn't mean it's anything like yours. They may even be getting chemotherapy, but they may be getting a different type of chemotherapy. So, I mean, you can listen to them, but don't take what they say to heart. You know, like chemotherapy years ago was horrible. I mean, we've all heard the horror stories of nausea and vomiting and being sick for weeks and weeks. Well, studies have shown that if we give all these pre-meds and prescribe antiemetics, that you're able to tolerate it. I'm not saying there won't be any nausea and vomiting, but we can control it. Where before it was horrible, and so people hear all these stories about how sick people are, and they don't want it. And I understand that. But if you have a question, let your care team answer your questions and not the internet or your neighbors. And don't sit at home and wait and say, oh, it's Friday night, I'm going to wait till Monday till the office opens. If you have an issue or a question or you're not feeling well, there's always somebody on call. You need to make sure that you know who to call and how to call them after hours and holidays. Some things could be an emergency and it needs to be attended to, so don't sit at home and wait for the office to open. And when we give you medical advice, listen to us. I know when you're told, oh, you need to go to the emergency room. Nobody wants to go to the emergency room. I understand that. I don't like to go to the emergency room myself, but sometimes there are truly oncology emergencies that need to be dealt with right away. And if in any way possible I can avoid my patients from going to the emergency room, I do. And this is something that all of us, not just oncology patients, but everybody should have their affairs in order. You need a healthcare power of attorney, you need a living will, you need to make sure that your financial stuff is in order, and if you have minor children, that you have their well-beings and what's going to happen with them in order. My dad did not have a will. He was very good to my mother, and he did everything as far as paying the bills. She knew nothing. She had no idea who they owed money to or what, which they didn't owe much, but she had no idea. She had no idea if he had life insurance. She couldn't find the titles to the car and the truck for years. She just knew nothing. So have your affairs in order. It makes it so much easier on the family. I mean, my mom got everything because she was still alive. So that aspect was okay with him not having a will. But if he had everything in one area, a locked box or somewhere, and told us where things were, it would have made it much easier on us. So take notes when you go in or ask for the information in written form. Keep a notebook and a folder with all of your stuff together so that you have all the information. And then if you have a question, you can look back at that information. And then if you think of a question in between your appointments, write it down in that notebook so that you can bring it back in with you for your next appointment, and then you can ask us. Be involved with your care. Ask questions. A lot of times I see patients just sit there and they turn to their loved ones to answer the questions, to find out the next treatment options. And I understand some patients are just like that. They'd rather not know. But be involved. Know what's going on with you. This is your body. You're the boss. Be involved. Keep a list of your medications. Have patients come in all the time with a little white bill, the oval peach one. Well, that's not very helpful, unfortunately, because depending on where you got that medication from, it may be oval and peach from one pharmacy, but from another pharmacy, it's round and white. We do have some ways of tracking them down, but when you just come in, especially when you're going into the emergency room with an emergency, or you're going to an urgent care, they need to know what medications you've been taking, especially if you have a rash, that you may have an allergic reaction or something going on. So make sure you keep a list of those medications. Second opinions can be helpful. And I can't tell you any oncologist that would get upset for you seeking a second opinion. They're here to help you, and they want what's best for you. Clinical trials are also wonderful treatment options. They not only can provide great care for you, but they also can help with patients down the road. That's how we get new drugs, clinical trials. And hospice. I know that's not something that you want to think about, but when the time comes and you have exhausted all the treatment options out there, it's a good option. And sooner rather than later. I have so many patients say, I'm not ready for hospice. Well, I don't know that we ever will be ready for hospice, but there's a time where hospice can be beneficial to you. And the sooner you enroll in hospice, the better you do. There's studies out there that show that if you enroll early on, I'm not saying day of diagnosis, but you've had 4 or 5 different lines of treatments and your cancer just isn't responding anymore. And the doctors have said, we've tried everything, we've done a clinical trial, there's just nothing new. I don't see anything new coming down the pipelines. I think we need to change our treatment plan to symptom management. We're not going to actively treat you with cancer drugs anymore. We're going to treat your symptoms. We're going to treat your pain. We're going to treat your nausea and vomiting. We're going to treat your anxiety, whatever it may be. We're just not treating the cancer anymore. And hospice has great tricks of the trade, as they say, to help control some of these things. Hospice was involved with my dad and my grandfather both. My grandfather was in hospice for over a year, and I had one patient that was enrolled in hospice for 3 years. Typically, we have to think that your diagnosis is less than 6 months, but we don't know that. So we think that your prognosis may be 6 months or less, so we enroll you in hospice. Well, 6 months comes, and you're still with us. Thank goodness. But you've declined just a little bit. They're going to continue to see you and going to reevaluate you. Now, I have had a few patients that have been on hospice and they've gotten better and they've disenrolled in hospice. And that's great too. But if you need hospice, don't shy away and say, everybody that goes to hospice dies. That's probably a very true statement in some way or form, but they're there for you and they can make your life better and really help your caregivers. These are some resources that we know that are good. The Linebacker Cancer Center website has lots of information. American Cancer Society, Cancer Care, the Lung Cancer Initiative has lots of information. Lung Cancer Alliance, Chemo Care, Cancer Grace, National Cancer Institute, North Carolina Radiation, Never Smokers with Lung Cancer, and Go To for Lung Cancer. Those are some reputable sources that if you just have to look up, if you're one of those people that like to know and like to look up everything, those are some sites that you could go to get some information that is evidence-based, doctor-approved, good information. So when facing the unknown with a diagnosis of lung cancer, many describe it like being in a storm of darkness, not knowing which way to turn, lost in the storm in the sea of life. And along comes the light of the nurse navigator to lead you through the storm, your beacon of light and your guidance through the maze of a lung cancer journey.